Oh, hey, Donna.
Um,
Um,
oh, there we go.
there it is.
Yay!
Welcome.
How are you doing?
I'm doing great. Donna, we have Jake with us as well.
Hi, Jake.
Hey, how's it going?
Good. How are you?
Doing great.
Awesome.
Jake, could you just remind us, who you are and what you're up to?
Okay, so my name is Jacob Gallion. I'm the Senior Geographic Information Systems Analyst here at Riley County, Kansas. Basically, we, maintain all the data for the city and the county, city being Manhattan. We also, manage the GIS website, manage all the geographic information data, applications and whatnot. So that's kind of what we do, probably similar to what GIS folks do at other counties.
Awesome.
Yeah. So Donna, you know me as sort of our liaison, the community liaison for the project, and you are the liaison in Wyandotte, if I remember right. So
That is correct.
And I approached Jake. What was that, Jake? Like just a few weeks ago about this mapping, trying to replicate this mapping process that Wyandotte went through, and we're just trying to explore that before we jump in there.
Drive safely.
Donna, could you just fill in Jake on who you are and what you've been up to?
Sure. So I'm Donna. If you haven't already gathered that, I am the project manager for the Health Equity Action Transformation Initiative here in Wyandotte County. We released a health equity report that was about 5 years worth of work with the Kirwan Institute for the study of race and ethnicity, looking at the connections between policy and systems and the impact on overall health outcomes. In that report, there are just a ton of maps and different data sets that we've used to really paint the picture for how systems impact health outcomes here in the county. We have some hot spotting data from the hospitals here locally, looking at patient cases and identifying them on a map and looking at hotspots related to emergency room utilization. There's a lot of data around where our moderate to high risk lead parcels are here in the county, and then a whole host of other data around vulnerable populations. We have a webpage, it's wearewyandotte.com, and there are just a ton of mapping resources that are located there as well. One of them is the opportunity map, which the Kirwan Institute has done that for several of the major cities around the country, Kansas City being one of them. And we worked with Kirwan to do some overlays where you can overlay that opportunity map over the top of some of the race data to really do some comparison about which communities are carrying the burden of lowest opportunities impacting overall health outcomes. So it's pretty cool. The website gets good traffic, and we've got a lot of interest. I'm doing a lot of heat presentations right now, so folks seem to really be interested in this work and like you all, very curious about how to replicate it in other places.
Great. And Jake, you've looked at the heat report, the physical document, the more sort of technical document, if I can call it that. In other words, not the comic book, and maybe you've also explored the website a little bit. So I just want to make sure that we're understanding what everybody knows and doesn't know and has seen and hasn't seen at this point. Am I capturing that right, Jake? Like you've gone through that document?
Yes, yeah, I've totally been through the document. I haven't explored the website though, so if you could provide that, that'd be awesome. I could check that out.
Okay, and I can send that to you later. And I don't think we need to have gone through the website to have this conversation here. But Donna, thanks for taking some time to meet with us here. I'd actually just kind of like to back up to sort of the beginning here, because to give you a little bit of context of where we're coming from, we're on Monday going to present this mapping. We've already been talking about this mapping project in our leadership team for our health equity project, and in our last meeting, which was basically a month ago, said, okay, we're going to explore more about the map and the feasibility of this, and come back to you, the leadership team, with some more background and understanding, kind of reading between the lines in the heat report that everybody's been at least mildly exposed to at this point. So I just want to be able to explain to them, give them sort of more of the story behind the maps and this kind of thing as well. So could you maybe start by just talking about like why the maps, like why did Wyandotte decide the maps in particular were worth doing?
I think there's a couple of pieces to that. I wasn't initially part of the startup of the project. That was my executive director, Jerry Jones. And we were both originally from Communities Creating Opportunity. And that organization, housed on the Missouri side, doing work in Wyandotte County, they did an initial run of mapping data around emergency room utilization and fetal infant mortality rates in Jackson County, Missouri, looking at downtown Kansas City, Missouri, and working with Trim and Med. And we're able to really look and dig into this idea of where are the concentrations of people who are having a really difficult time getting access to care for either chronic disease management or prenatal care. And they really looked at those folks that were visiting the emergency room in excess of a set number of times, whatever that might have been for Truman. I know what it was for us, and I know what it is for Shawnee Mission and the work that they're doing. But it just looking at your frequent flyers in the ER and then identifying, plotting them out on a map, and doing whatever you need to do to kind of hide people's actual address locations. There's ways that you can do that in the GIS process, but getting a good idea of an overall hotspot area, and then having dialogue about how do you then begin to address the needs of those vulnerable populations through community engagement. And so through conversations with community, understanding what are the limitations, what are the pokes in the side, what is making it difficult to get access to care, and then working as a collective group or a collaboration to provide resources into those areas. And the Trim and Med group, I think they played with some mobile clinics, putting vans in these areas to help bring prenatal services to the community. And from that experience, with just looking at that hotspot hospital data, then the funders got together and talked about Wyandotte, and there was this movement to then have a similar report done for Wyandotte County. And so we started with the hospital data, looking at KU, looking at Children's Mercy data. I think there's about 45,000 patient cases that were looked at between the two hospitals. And the hotspots came out in the same areas here in the county, around the 10th and Central area, which is where we identified in both cases where people were more likely to access the emergency room for chronic disease management, and we were more likely to see readmits and returns to the ER. So we know people are going in, getting immediate experience and fix for a problem that day, going home and not having the resources that they need to continue to be healthy once they've had that Band-Aid fix in the ER. Oftentimes in those conversations, those physicians are saying, hey, go back out, see your primary care physician, here's your prescription. And these folks are going out with oftentimes no insurance, no transportation, no primary care doc, and no way to follow the orders that they were given in an emergency room setting. And that ultimately led to, okay, well, we need to understand what else is out there. Why is it the way that it is? And why do these same neighborhoods come up, regardless if it's Children's Mercy Hospital or KU Hospital or Shawnee Mission Hospital? Why do we continue to see the same populations in the emergency room? And that led us into backtracking into the data and looking for links to systems. And when we start talking about healthcare, it's really easy to link healthcare to zip code. And it's really easy to link zip code to the community and the way the community is shaped, which ultimately leads you back to policies that have shaped the way American cities look today. And so it was very easy for us to kind of make the stretch and go into this idea that the housing practices and the housing policies over the past century have really shaped the way communities look today. And then that leads to then, well, what is the ultimate outcome of that? And we start looking at all these different health indicators. So looking at what are people dying most frequently from? What is the average age of death disparity? We would have liked to have had an actual length of life measurement, but due to some data challenges, we had to go with average age of death because that's the population data that's available. And looking at things like, okay, well, we now know people are dying 20 years earlier. What are they dying from? So that draws out the cancer, the heart disease, those things that are lifted up in the reporting. And then again, we just keep asking these why questions, and it leads you into all these different areas. And you talk about average age of death, so life expectancy, then you start having conversations about, well, what does it look like from the very beginning, from birth, that took us down the road to femur. It's just one thing leading to another until we have this comprehensive, overarching piece. The mapping for us was critical because it's allowed us an opportunity to have an equity conversation in a space where that hasn't happened before, right? This idea that there's inequities in a county that's already itself part of a disparity conversation. So yes, Wyandotte County, Johnson County is just south of us. There's always that comparison, or even Kansas to Missouri. But even inside our county, we see the same challenges, right? This inequity.
Right. Good. So let me just touching on a lot of the different questions that I had. So how acceptable? Well, let me back up a second. So who have you been finding yourself having conversations with about equity? Like, in other ways, like, how are you? Can you talk more about the ways that you're sort of operationalizing that? Like, who are you talking to?
Yeah, so the community health councils, I think, uniquely situated to be a catalyst for collaboration in our county. So we have a space that provides an opportunity to bring people together. That's the start of it. And we're situated right here in downtown KCK. And we have partnerships with the local safety net clinics, the hospitals, the health department, all of those kind of key organizations, social service agencies around the county. Being in community allows us to also have a conversation as the Community Health Council. We're not government, we're nonprofit, and so we can have a different relationship with residents. And so we're able to have that conversation as well. There's been a lot of folks in the academic environment that they have just latched onto this report. And so we're acting on this in a lot of different ways. So making sure that we've done presentations with the Mayor's Health Council and commissions, making sure that we've had one-on-one conversations with local elected officials and leads in government position to be able to make decisions around some of these issues. We've had conversations with obviously our medical partners and clinical partners across the county. And we started there. And for me, from the very beginning, there's this, I guess, this dream at this point that we're working on, where this is being rolled out and discussed with community by community. And so we came together and identified a few community leaders to be part of the community advisory board. And they quickly decided they didn't want to be advisory, they wanted to be action. So we're not just going to talk about it, we're going to do something about it. And so this group of people in community have sat through the presentations, asked the hard questions, worked through a root cause analysis discussion to identify where do we start to make change. And from that, they've divided out into two subgroups, one working on walkability in neighborhoods. We had a group of kids that had this really cool idea to build pride in our community, because there is this kind of collective depression in the county where there's a stigma associated with being from the dot. And And so part of that is this, you've been told enough times that you don't matter through actions and words to the degree that you start to believe it yourself. And so how do we begin to change and take pride in our community? These kids wanted to put their names on the sidewalk in front of their house, invite their neighbors out to do the same, and talk about, this is my name, and here's one word that describes why I'm great and why it's great to be from the dot. And what we realized really quickly is it was this great, beautiful idea, but they don't have sidewalks. So like to implement this thing, they don't even have what they need to do something very simple and take pride in their community. So they decided to start working on walkability. And we've got community neighborhood volunteers, kids from the local middle school here in the Northeast, doing neighborhood audits and doing sidewalk audits with the DOT agency and KU School of Architecture and a local MBR here. That's one subgroup. The other subgroup recognized early on that people who are in decision-making power have an impact on their day-to-day life. And so they have got to take some action, and as it relates to having a meaningful conversation with elected officials beyond the doors of the commission's chamber. And so they've identified this relationship building effort for CAB members to have a relationship with those people that are in decision-making power, to be able to articulate, here's what's most important, what's most painful, what's on our plate, what does this mean to you? What are you concerned about? And to have this exchange of information to understand what their value set is, because we know values lead to decision making, and for community to be able to help inform and hopefully advocate for the things that they want. And this group has held a couple candidate forums. They're in relationship building conversations now. We just finished the election, so we've got some changes in leadership that they're going to have to work through and do some research actions with the new mayor. So there's a lot of initiatives that are underway. And then starting in January, we're taking the same community action group, which I think I sent out the last text message. We had 38 people on our distribution list in community, which is unheard of from an engagement perspective for a group to come together and work. That's a lot of folks, but they're doing great. The goal is for those folks in the Community Action Board to go through a human-centered design approach, kind of a project where they're not just doing the project and identifying a new third category to focus in on, but to also learn the elements of human-centered design so that they can continue to prototype after this group who we're bringing in leaves from community. And so it's kind of a train the trainer process, but having an actual output at the end. And so they're going to do some deep engagement, being trained to have meaningful conversations in community settings. So whether it's a dining room conversation, a living room conversation, to take elements, the 4 key topics from the heat report, have these conversations, and then bring those folks that they've had conversations back into a collective experience to workshop. How do we identify this thing we're going to work on together as a larger cohort? And so we're kind of going through that process, and we're bringing these CAB members through KLC. So we've already had 12 of them attend, which is fantastic. And then they'll be able to replicate this human-centered design approach by the time we're done with kind of this next 6 to 8 months.
Wow, that's really impressive. You're doing all of this community development, work, if we can call it that. How easy or hard would it be to do all of that same work without these maps?
The maps give us an edge when it comes to people who are naysayers. So, right, when you run into the resistance and those folks that are like, it's not as bad as you're making it out to be, then we lean into the data. And I think the other piece that's an advantage for us with the data is for the CAB members to be able to pick this thing up, right? Whether it's a video or the comic book or the report itself, or the maps from the web page. They have all these tools. They can pick it up, go into community and like present this thing in their own words. So it provides the thing to present. I think you could still do all of these things without a fancy report. There isn't anything I think that's limiting people. I think it's giving us a little bit of an edge for the data junkies in government, right? To be able to get them to go down this process with us.
Yeah.
And for me, it's critical for this report to truly be the community's report. And I think that's one of the defining differences. This wasn't something that the local unified government put out. It isn't something that one of the local hospitals put out. It is from a community organization for the community to act upon.
How important was the historical analysis part of the report?
It provides us with an opportunity to have a conversation, a real conversation about policy, which I don't know that that's a common conversation that you see in underserved communities, where folks generally think that they have zero power to make any changes and it's just the way it is. And so by providing that historical context, one, it provides some vindication. We've had community members break down crying and basically in asking what's happening right now, what's this thing that's happening inside of you, and it is vindication. And so I think it provides a level of trust in the process. It relieves the burden of people feeling like this is going to be a victim blaming process, and provides a little bit of relief, right? Because oftentimes people are told it's your fault, right? You're making bad choices, you're smoking, you're drinking, you're using drugs, you're not taking care of your house, you're blah, blah, blah. But this provides a different context that takes some of that piece away and just talks about the reality of your neighborhood looks this way because of all of these things that have happened throughout the past 60 years. And you're here now in this space, and because you're here, we invite you to be part of solution making. So it takes away, I think, this idea that you deserve this somehow because this is your fault.
How you mentioned, you ran into like pushback from different audiences, and you had in talking about health and equity, and what audiences are you finding the most resistance among to like these kinds of conversations, or even the maps themselves? Like, who is saying like, I don't know, I don't really buy this, if anybody?
I haven't had anybody outright say that, and I don't know if it's because we're Kansas nice or why that is. But there generally are two factions in the room. There's the group of folks that live this experience every single day, and they are feeling vindicated, and they feel emboldened to actually say, to the other side of the room, this is real. This is what I go through every day, and they're able to describe the lived experience. And so we like to have, when I present, I like to leave about 30 to 45 minutes for discussion, and that's what happens. People, they feel emboldened to speak up. And the other side of the room generally is either very quiet, or there is an outspoken group that's talking about, I had no idea. And so that's where some of the conflictual part of it is these folks that live it every day looking across the room at the folks that are saying, I had no idea. Like, how did you have no idea that this was happening? We've been living with this our entire lives.
Right.
But I think there is, generally speaking, a sense of compassion and outrage, even in those folks who had no idea, enough that they are asking, so what do we do about it? Mm-hmm. And the reality that it's a complex problem, that It isn't something that's going to be solved with a one-time magic bullet.
You mentioned that not every community would need a sort of polished sort of document, or even sort of suite of documents and products that like Wyandotte has, between the website, the comic book, the heat report. And so I'm wondering, and I'm aware that you spent quite a bit of money, having the folks at Ohio State help you with this. Is there anything in your mind at this point where you're like, if I could go back and do it again, I wouldn't spend money on this? In other words, like, could you have had the same kind of impact with less investment up front? somewhere.
I do think so. I think what we're doing now, and in hindsight's always 2020, thank goodness for that, right? But
Yeah.
I think what we're doing now, the way that we're moving into action, if we have, because we're using 4 topics that are the things that have kind of risen to the forefront from the report. So lead being one of those issues. We know that about 50% of the homes in our county are at moderate to high risk for lead exposure for young children. And they are highly concentrated in the areas where children are concentrated. So there's a data about where our children are, and there's the data about these lead concerns, and together gives us this context and conversation. I think you could probably take that data without all of the analysis, look at it on a map or in that context on mapping and GIS, and have a conversation around it. I don't think you need a full analysis like Kerwin provided. I think too, you can do the same with the femur infant mortality data. So that's another one of the issues that are rising to the forefront. That's open data from the state. We know what our femur rates are. Every county generally in Kansas right now has some sort of a femur team working on it. You know, if you were to engage with that piece of data, you could still act out and do the same things that we're doing with the CAB and with the community engagement process. So I don't think it takes a fancy report. I think it looks great and it's cool and it's attention grabbing, but I think you can do the same work that we're doing now with a few key data points, you know, that's accessible.
And so would you say then, like this, the opportunity index was not really essential either, or what, how do you think about the value of the opportunity index? Because that seems like a pretty, you know, I don't know, like a lot of thought went into that.
Yeah, not just a lot of thought, but I think a whole lot of work in pulling together a lot of information. So if I wouldn't think it would be very hard, and this may be me being naive, but I don't think it would be very difficult for Kerwin to apply the same measure and techniques to create just an opportunity map for another area, just like they've done for every major city across the country. As long as there's enough data to pull, they should be able to replicate that pretty easily. For us, the opportunity map helps to illustrate who is carrying the burden of lowest opportunity. So it really makes the case for where investments are happening. We're planning what we're calling a funder discussion in March, where we're going to pull together folks that are doing good work in the corridor that we've identified as the area with the lowest opportunity, along with, so many of our partners, along with a whole host of different funding agencies, both corporate and business and in philanthropic nonprofit institutions, having this broader conversation about what would it look like to take a longer term collective investment in an area like a Harlem Children's Zone approach to address, and the opportunity map gives us the basis for having that conversation. So I do think it's important. I think less important to community because it's complex, and I don't know always that the opportunity map resonates with community. To me, it's once I go through all those vulnerable population maps and I highlight the same areas over and over and over again for all of those vulnerable populations, I throw that opportunity index up there, and it helps to reinforce why it's so critical that we do look at these areas and that we do work towards equity and that we do try to fill the gaps for those missing opportunities that don't exist today. But I will tell you, for community, that's not the most important piece. It's the really hard statistics that deal with life and death that resonate with community. The opportunity map for funding, though, is absolutely essential.
Yeah, I might even say, you know, we in Riley County, because I'm not, at least at this point, I'm not aware of any like of that hard hitting data and disparities between, you know, census tracts that would emerge the same way that they do in Wyandotte. That maybe the best way to visualize opportunity here would actually be to use those layers. Like, you might not actually see those disparities quite the same way until you did those, until you put together that index. But that has yet to be determined. So Okay, so Jake, you wanna jump in here and ask any questions that you had lingering?
Sure. Yeah. So, basically, my main question was on the development of the index, and it looks like you guys had Ohio State do that. Is that correct?
Yeah, that was an Ohio State initiative. Yeah.
And then, did you guys produce internally all the other supplemental maps?
We worked with Kerwin. They actually did the bulk of the mapping for us. So we
Okay.
we coordinated the partnerships between the hospitals for them to be able to access the data and the I guess the huge data sets for all of the patient records that we were able to use. We helped to coordinate the relationship with Kerwin and KDHE to get the access to the population data, which you find in all of those vulnerable population maps. Worked with the local health department when it came to the average age of death to try and get the information that was necessary. So we did a lot of the coordinating between different groups to make the resources available to Kerwin and make their job easier. But they actually did all of that mapping process for us.
Okay. And then, as far as the overall project, I think you said it took about 5 years. Is that correct?
Yeah, I think from initial concept to getting the funding, then moving forward, it took about 3 years for the report itself. And I will tell you, it probably didn't need to take that long, but there was about an 18-month window where the person who was project managing left the organization and it sat dormant. And that's really where we moved it from CCO to CHC. Organizationally, where it was being housed, so that we could kind of take it and really at that point relaunch it and run with it. The report itself probably could have been done and done well in the course of a year rather than in 3 years.
Gotcha. Cool. And then, like, what other challenges with a lot of the local data sets? Like, I can go obtain a lot of the same census data that you guys use, but like, what challenges did you face? Was it just kind of obtaining the data sets and coordinating, or what all did you face?
Yeah, so working with the hospitals, of course, you get into HIPAA. So there was, this need to protect patient information and going through the agreement processes. And anytime you're doing that with large institutions, it generally takes a lot longer than you think it would. And so that was one piece that we ran into that was more cumbersome than I think was anticipated. Really beyond that, just getting through some of the MOUs and contractual things, everything else, probably pretty much the case across any municipality is trying to get past some of the red tape with getting access to what you're looking for.
Okay. And then another thing I was curious about, I'm trying to remember, when did this come out? When did you publish this? Was it just a few years ago?
It was November 28th last year when we released it.
Last year. Okay.
Yep.
So I'm just curious, like, why you guys chose like a PDF, like printable document versus like maybe something more interactive, or maybe it is on the website and I just haven't looked at it yet.
Yeah, so when you go to the website, you'll see the PDF, the downloadable version. We provide print copies here. The maps are most of them, not all of them, but most of them are broken out in an interactive mapping feature. And so if you click on the link that says the maps, it'll take you to a page, and they're overlaid in an interesting way. And so you're able to, like I said, take that opportunity map and spread it over the top of like the race, the predominant race by neighborhood map. And then there are some other comparisons. I'm trying to remember exactly how they all look. I know one has the lead map, and it has some of the neighborhood track data, and then there's one that has the average age of death and the mortality, the neighborhoods with the greatest mortality around cancer, heart disease, and stroke. So you can overlay, and it's interactive in the way that you can also click on, in those vulnerable population maps, you can click on the census tract, and it will pop up a window that shows you all of the vulnerable data statistics for that census tract. So you don't have to go tab by tab by tab. You can actually click one open and then you can see all the data. You can also search for a specific address. So when I'm meeting with residents and we're having this conversation, it's this moment of epiphany when you're able to pop in their address and zoom into their area and then talk very specifically about the census tract that they live in, and what are the opportunities and restrictions, what are the vulnerable populations that exist there, and what do they look like in comparison to other areas. And so when I do presentations on heat, I generally pull up our webpage and I present straight off of those interactive maps.
Makes sense.
So Donna, that brings up a interesting question about, I guess we could call it, deficit-based versus asset-based, right? Like community engagement, and how do you approach that? Going into somebody's living room and saying, look, you live in the quote unquote worst census tract in the county, and how is that, how are you dealing with that?
Most of the time they already know. They don't know like the worst census tract, but they already know it sucks. And so the conversation is talking with them about their lived experience and always going armed with some resources. So I'm fortunate to be sitting at CHC. We have resources available that identify where our safety net partners are. So if we have someone who's in the hotspot community for the hospitals, they've talked about how they have to use the emergency room and talked about why. And sometimes it's transportation. Sometimes they just didn't know that the clinic was there, or they weren't sure when they walked in the door because the person sitting behind the table didn't look like them. They didn't feel comfortable staying. And so we have 7 community health workers here that are right here in community that can help facilitate connecting them with those resources. So when we have this conversation, we're not just going in and saying, gosh, doesn't it suck to be here? We're also saying, we know it sucks to be here, and here's our bag of tricks when it comes to getting access to resources, and we'll continue to strategize with you to put more things in that toolkit.
Right. So I think I only have one more question, and it occurs to me as we're thinking about like the different kinds of maps that one could use to stimulate these conversations. And we're talking mortality rates and infant mortality rates and lead and these kinds of things. And but why not just a poverty map, right? Like, I mean, how much is wrapped up in just that one sort of metric there? And I'm kind of aware of some of the limitations of doing that, but I'd kind of like to hear your perspective. Like, why not just poverty maps?
So I think that you can accomplish a lot that way. And again, you're talking to a group of people who are living the experience every day, and they're probably going to have a great conversation with you about that. I think and maps specifically, when you walk in with something that isn't just county-based or isn't just city-based, isn't just all of us in this area, but you get right down to, this is my neighborhood, and this is what it looks like in my neighborhood on a map. I mean, you can have a conversation about poverty, or you can have a conversation about fetal infant mortality rates. We know which neighborhoods are most impacted and lose babies before their first birthday. We know which neighborhoods where people are more likely to have a toxic exposure from something that's just literally across the rail yard, right? When you get into those situations and you can get very specific, and poverty is so broad, drilling it down and being very specific allows you to have a different kind of conversation. You can have a great conversation around poverty. You can have an even better conversation about this issue that affects people's health in a very tangible and real way.
Right. Good. And you mentioned like a bunch of academics are jumping all over this, report. Like, what I don't know, what are you hearing from them? Like, what's the interest there?
We have, I've presented this information at for KU School of Social Work. I've done the presentation for UMKC, Health Sciences, Mid-American Nazarene University in their health tract. I can't remember if it was public health or another one. And usually once one professor like gets their hands on it, they're referring it to the next one. And so it just kind of bounces around. The really cool part, and I think the most interesting part for me, is the high schools and the middle schools that are now engaged. So we're working with 3 of the local high schools. There is a metro-wide project called Race Project KC, and that group involves Shawnee Mission East, which is in Johnson County, Paseo High School, which is in Jackson County, Missouri, and Wyandotte High School here in Wyandotte County. And these kids are all from, like, different tracks. And the Shawnee Mission East kids would be your A neighborhood, every amenity you could think of, have no idea about what it's like to be impoverished or have limited opportunities. Having conversations with 2 other high schools where they live that experience every day, those conversations are powerful, and they're having heat presented alongside things like bus tours in this area, in this neighborhood that's not redlined, and this one that was, and having these data gathering discussions where they have the kids doing physical counts, doing some data gathering, and then taking that and turning it into something interpretive that they're able to present in the form of art. And so really interesting spins on some of this data and this idea of policy linking to health outcomes, and community in your zip code really defining your potential for having a healthy and happy life. And so for me, I think the piece that's most interesting is working with the young people, and here especially having a conversation about what it means, because most of the kids here, they just want to get out. So how do we have a conversation about not getting out, but changing what it looks like, and you can start changing it today, and getting these kids involved in different projects.
Right. And I was just going to ask you about that. Like, I imagine with all the conversations that you're having, and, the exposure of this report now, like, it's really probably challenging some narratives that, that the county has, told itself about itself for a while. And I'm just kind of wondering what some of those narratives might be, if you're aware.
I can tell you that it's interesting. We just finished up this mayoral election, and our mayor, who was super health centric, really understood the connection between government policy and health outcomes, is no longer going to be holding that seat. And so I think there are challenging narratives. I think there are things that we're up against. We did this presentation at the mayor's health commission, which is a lot of his partnerships with different factions across community. And folks in the room, you can tell when they're checked out, they're not paying attention. They're on their phone. They're kind of sitting back with their arms folded, kind of that look of like, this is some liberal BS. And I think this puts people in a situation with some hard data that they can't really ignore, that they're going to have to come up with a different way to try and explain away. And so there's a piece of that, I think, that's happening, and probably not unlike a lot of other situations across the state, across the country, where it's easier to just deny it than to accept it. But I think that when we start dealing with the kids that are here, the kids that are going to be the future, I think we've got quite a lot of hope. And when they're able to find their voice and they're able to share their story and it's substantiated by data, it's kind of hard to ignore. Yeah.
And I'm aware of like some of the ways that you're pairing those narratives with the data. Like, I look at your website, and there's several videos on there. Are there other ways that you're incorporating narrative into that I'm not aware of?
Probably not at this point. I think that we've got a couple folks that are very interested in helping to build out. So redlining, policy from the 30s that ended somewhere between 50s and 60s, right? But we know that there were still discriminatory practices taking place. There's a whole list of policies that we haven't fully explored in the document. We have folks that are coming to the table who are saying, I will help carry that message, carry that story forward. and researching those other policies to really begin to connect the 30s to today, and highlight how one thing kind of dominoed into the next. So building out in more detail what's in the report. And so that's kind of happening on the backside right now. I think the most important narrative that we have to share is the one of lived experience and inviting community into that space to do that.
Right.
Because that lived experience, I think, is the most powerful part of the conversation. I grew up here, so I can talk a little bit about it, but I don't live here now. And so having people that live here now that both grew up in it and are able to really take you through the timeline of what it used to look like and what it looks like today, and from their perspectives, the things that impacted that, right? So how did that policy actually live itself out in community? That's why their stories are so powerful.
Right. Yeah, I think this is just I'm amazed every time that we talk about this, like the depth and richness of this project and the amazing impact that it's having. It's very inspirational.
It's a lot of work, but a lot of fun.
Yeah, indeed. Jake, did you have any other questions for Donna?
I do not.
Okay, Donna, do you have any questions for us about anything?
Is there
very one-sided so far?
That's okay. Because I'm interested to hear kind of where you are, Brandon, with how you're moving forward with this KHF project and how you see these things kind of interconnecting. And then the second question I would have for both of you is, how can I help with connections, with resources? In what way can I support what you're doing?
Great. Yeah. Maybe I'll start with the first one there. So with our health equity project, and I'll say that, we're talking about a community that's a coalition that is not as well developed as the one in Wyandotte. We have a fairly young coalition. We don't have community health workers. We're still kind of operating on largely under a traditional health department kind of model, right? Community health improvement plan, get the CHIP program out there and right, whatever. So very little community engagement. And so we're doing two things right now. One is we are building our own capacity to do community engagement work. So we've got a bunch of people on our leadership team who have virtually no experience or very little experience with this kind of work. And so we've been, going to leadership trainings. I actually just went to a community engagement fellows or community engagement workshop through our Center for Engagement and Community Development at K-State, which does this kind of work in a lot of different ways. They are very skilled in community development, and a big part of that is hosting community dialogues and different streams of community engagement. They call it a number of different things, deliberative democracy and different forms of that, world cafes and whatnot, right? So like facilitation type of skills. We've also been just applying for more grants, actually. So we knew that we were going to need more money to support, community champions and neighborhood volunteers or neighborhood, advocates. So we've done some of that and been successful in that. We've also been just really trying to strategize here and identify who our priority population is. And there was a lot of discussion about what the best strategy to do that was. And, we dug into our experience with community engagement and community organizing. We have a few community organizers, one on our leadership team and some, who are sort of tangentially related to the project, and dug into some of the literature on this, on community organizing and how do you define, communities, right? Like how do you even start community organizing? And we have basically come to the point where we're going to define our priority population in terms of a geographic location, at least to start, right? So the mapping here makes a lot of sense. So we actually use the existing census data that we have, along with some other local data from a food systems study that was done just recently that identified food deserts. And, we're basically taking what we know about the food deserts and poverty and child care or lack thereof in certain areas of town and saying, okay, here's a good place to start. So we're going into one neighborhood to start some dialogues and start some conversations, the authentic engagement, as the Kansas Health Foundation would put it. So, so our leadership team is largely made up of academics at this point. It's about 10 people large. And on Monday, we're actually going to begin a split. So we're sensing right now that there's really two sort of fronts that we need to be working on. One is the community engagement piece of this, really just starting some community dialogues and organizing. And the other front is the maps. So we're gonna, and there's people on our leadership team who are, pretty well equipped to do those, but maybe not both of those. And so, so it's time to start dividing and conquering, and actually, frankly, give back some of the work to our leadership team that's pretty well equipped to do those two things. So on Monday, we're going to present the maps as one of the sort of subcommittee projects for our leadership team, and then also the community engagement side of things, and then just go from there. Kind of act in the community engagement work, acting experimentally, and seeing what happens. Hopefully, doing a pilot session before the end of the year, and informing a more comprehensive engagement plan that I'm aware that you have now for after the new year. And then the mapping side of this, we're hoping will materialize at the end of perhaps the first year, not the grant year, but the calendar year, so end of 2018, so that when it's time to, we've gone into neighborhoods and had conversations and identified some priority health equity issues. Those maps will start to be coming out that we can use for advocacy tools, and also to perhaps reach out to other neighborhoods in the community and to start that work. So hopefully those two things will time up well. But in any case, we think it's worth doing for basically all of the reasons that you just mentioned. So
that's awesome.
Yeah. So as far as how you can help us, Jake, maybe you have some ideas about that on the mapping front.
Yeah, I would be interested in obtaining more information as far as like when you guys approach the health facilities and hospitals to get data sets, how you actually went about that. I've never had to contact health related facilities in order to obtain that.
Okay. Yep. I can pull some data together on that. Probably have to lean into Jerry and have him kind of describe that process. He was intimately involved from the very beginning. So that's my executive director is Jerry Jones, and really kind of the brainchild for this. And he just left it in my hands to try and pull it together after it was stalled for 18 months, which we were able to do, and it's great. But a lot of that work actually happened before I got involved. So, but I think there is a lot of information available. I know he has fostered those relationships, and we have invited those same entities into the work, around some of the different issues that have come out of the data. So I'm happy to see what I can find when it comes to best practices for reaching out to those entities and saying, hey, can I get your patient data? Because they're not super happy to give it up.
Yeah, exactly. And I did find the interactive web page that you were talking about, the mapping application, and we've put together some similar things that are like this. So I think I got a pretty good handle on the mapping side. It's going to be more on obtaining some of those data sets that we need. I think will be a challenge for us, but I feel pretty good about that.
Negotiating it in a way where they don't feel like they're giving up too much information, but just enough for you to conquer what you need to conquer.
Exactly. And I don't know, Brandon, maybe you guys will be involved with that more than I will, but just something to think about. So.
Yeah, for sure. That might be a conversation that we have with our leadership team on Monday, or a conversation that happens within the committee work, if we decide to move forward with that, which I think we will.
I can tell you out of the gate, one of the most important pieces is finding a champion that's inside that system. We had a physician both at Children's and a physician through KU Family Med, who was able to champion on the inside what we were asking for from the outside. That makes one heck of a difference.
And so it didn't necessarily have to be like an administrator then either.
No, generally speaking, people that are in the system are going to know who are the people they need to kind of work through in order to get things accomplished. And we worked with he's a family physician doc who works with the immigrant population here, but also is doing a lot of research for the hospital. And so he was able to, through his own experiences and research, know who those folks are that he needs to work through to get the data. And having an internal champion oftentimes will get what you want expedited, because it's kind of pressure from both sides.
Great. Good. Donna, is there a way that we can be helpful to you? Other ways that we can be helpful to you?
I'm always open to ideas and suggestions and kind of new ways to get it done. So if there's anything that I've said that's prompted an idea or spurred a thought, definitely open to that. So yeah, I think it's I would love to kind of continue to have regular collaborative conversations and just kind of hear how things are going. And maybe if we run into a challenge here, we throw it at you guys. If you run into a challenge there, you throw it back at us, and kind of see how we work through those things together.
Yeah, I love it. I love the sort of learning community, or what do they call it? Community of practice.
Yes.
Sort of concept. I agree. I think it's a great idea.
Awesome.
And I will do that.
Cool.
Great. Well, Donna, thanks again for your time.
Hey, great.
Good to see you again too.
Yeah, it's nice to meet you, Jake.
Yeah, nice to meet you.
All right. Have a great day, guys.
Okay. Take care.
Take care.
Bye-bye.